Hello everyone, let's go ahead and get started on my complex clinical case study. So I have this 6-year-old Hispanic male who presented to the ER, worsening shortness of breath. He had had hemodialysis done the previous day. He's a typical Monday, Wednesday, Friday patient. Pretty much, even though he had the dialysis, complained of progressive shortness of breath since he left the clinic. Wasn't able to catch his breath. Had some chest tightness and kind of a short cough, as he stated. No fevers or chills. He also complained of a light headache after dialysis. Kind of one thing that we got out of him that he did initially state was that the night afterwards he had a 6-pack of Budweiser with his friend who had came to visit him. So that was kind of information that was left out initially. So this gentleman's history: coronary artery disease, diabetes, hypertension, kidney stones, ESRD, HD for the past 6 years, Monday, Wednesday, Friday, and he had a TIA in 2015. Past surgical history is stents times 9, CABG times 4, cholecystectomy, bowel resection, AV fistula in his left arm, and bilateral knee replacements. Family history: heart disease. Social history: denies ETOH use, but then he admitted to it. He says he was a former smoker and he hasn't smoked in 10 years. He is widowed and retired. He does have allergies to hydrocodone, penicillin, and codeine. So, review of systems: no fever, no chills, weight gain from previous weight, and generalized weakness. From a neural standpoint, denies any focal weakness, denies confusion, lighthead. HEENT, he uses corrective lenses, hearing aid, and partial dentures. Respiratory standpoint, like I said, increased shortness of breath, dyspnea on exertion, and mild cough. Cardiovascular: complains of mild chest discomfort with increased discomfort when lying down, denies any jaw pain. GI: he denies nausea, vomiting, maintained appetite, constipation greater than 3 days, occasional bright red blood on forced BMs, occasional bloating. GU: he is oliguric, since been for several years now, musculoskeletal, complaints of knee pain with climate change, back stiffness. From a psych standpoint, denies depression, does have family support. On physical exam, his neuro: ANO times 4, no deficits really present, EENT, atraumatic, normal sclera, clear cornea, normal mucosa. Neck did show some JVD, 10 to 12 millimeters. From a respiratory standpoint, did have Sorrell's rhonchi present in the upper lobes, distant breath sounds in the lower bases, and dyspnea presented. CV-wise, upper and lower pulses palpable, heart tones normal, no signs of murmur presented. GI-wise, had abdominal distension on palpation. GU, he was oliguric. Skin-wise, he had AV fistula in left arm. Brute present, no other issues noted. Did have some trace edema in the bilateral lower extremities as well. So on lab presentation, kind of things that were significant: his sodium was 129, potassium 59, creatinine was 7.16, glucose 348. Myoglobin was 356, troponin was 0.92, and BNP was 5,893. Everything else on there was normal in value. Negative D-dimer, negative pro-cal. So some of the diagnostic findings we had: we did a chest x-ray. He showed some mild pulmonary vascular congestion with the right pleural effusion and some right basilar atelectasis. 12 lead EKG, normal sinus rhythm, short and QT interval. So our differential diagnoses: first one was pneumonia, just due to the positive findings. He had the pleural effusion in that X-ray. Some of the negatives that came with it was the negative lactic acid, no fever on presentation, normal WBC, so wasn't showing signs of infection. Myocardial infarct was the second one. Some of the positives were chest tightness, shortness of breath, and elevated troponin. But it was probably just some oxygen ischemia from the demand of his body having to work so hard and it was overloaded. Negatives wise, normal EKG, decreased troponin levels on the repeat sets. Third was pulmonary embolus. Some of the positives were shortness of breath, but his negatives were he had a negative reading for a D-dimer. So primary diagnosis on this case was acute CHF exacerbation. Kind of the patho that kind of goes with it for this gentleman in particular, the fact he has hypertension that's uncontrolled, kind of increases that afterload, decreases the renal perfusion, so his kidneys are already shot. So in coincide, he has ESRD, so no urine being produced, he can't excrete any waste or excess volume, causes the volume overload. That excess volume overload causes excess pressure within the heart, that left-sided heart failure, reducing cardiac output, leads to pulmonary congestion due to it reversing kind of flow into the lungs, and then you get that acute CHF exacerbation. So the assessment and plan for this gentleman, we'll go through systems neurologically. He's learning-oriented, conversational, so just continue with Q12 neuro checks with him. And then that's it from a neuro standpoint. I guess we were also contemplating something for anxiety. Something for anxiety if for some reason he was having shortness of breath and we weren't able to treat it just with the dialysis. So just kind of have some med on standby for that. Respiratory-wise, continue with the HD with titrate oxygen as necessary, and PRN will use BiPAP. Just PRN BiPAP orders. We're also thinking of maybe adding some morphine to the regimen as a kind of adjunct if for some reason we're having some issues with oxygen demand, maybe kind of reduce that need. Cardiac-wise, we're going to do echo study, consult cardiology, continue home, BP meds, strict INOs. Really, this gentleman just needs to be dialyzed. GI-wise, start him on a stool softener, carb control, renal diet, fluid restrictions to 1.5 liter, dietary consults to educate, and KUB just to make sure he's not impacted or there's anything going on with his gut. Renal-wise, continue with his Monday, Wednesday, Friday ESRD, just add an additional HD treatment until we get to baseline for him, and then we get lab correction as well. From ID, we'll continue daily CBC, CMP, follow up with the X-ray to make sure we see improvement in that chest X-ray. From endocrine standpoint, we'll start him on an insulin sliding scale, get an A1C on him to see his diabetic compliance, and do some diabetic teaching. Musculoskeletal, PT-OT eval, ambulation, get him walking, get him going. Minimize kind of the muscle wasting. 10, do some DVT prophylaxis, Lovenox injections per protocol, and start him on H2 blockers such as Pepcid. So really kind of key points that we need to strain on this gentleman is he's going to only worsen his cardiac cycle by, not being compliant, not monitoring his intake and output. So, just educate him that he can't be drinking an excess amount like that. And then, again, with the diabetic teaching, due to the fact he already has significant heart history, he's at risk of, potentially having another MI. Thankfully, during this visit, that wasn't the case. So just reinforcement on all that, and continue treatment per guidelines. That's it for this case study. Thank you.